Christine, you ready? Can you hear me?
I can.
Exactly.
All right. Would you mind on that one? Perfect. Yeah. So, hey, I want to thank you guys for coming to the this Q3 third quarter. No, this is third quarter. Third quarter forum, right here. No. For coming, and so we're going to talk a little bit about what's going on, and then we're really going to try to move a little faster through things so that we can have time to do questions and answers. And if you guys have a question about anything I talk about or anybody else talks about, please stop us and we'll take it then. We also have some questions from the box that we have out that if you guys don't have any, or it might stimulate some thoughts, we can do that as well. So again, I am Skip Gjolberg. I'm your administrator here. Been here since October, so we're about 9 months into being here. And oh, there we go. So I always keep talking about our mission because our mission is really important. And the thing that I think I really want to point out is meeting the needs of the people, and because the people are really kind of why we're here. We're here for the people. We're here for our patients, and we're here for each other. But we want to make sure that we are always focusing on being able to provide the best care to the patients, and it's what we're all about. It's what you guys have done since 1970, and before that, when the other hospitals were here. And it's what makes us different. It's what makes us, I think, a great community hospital. And the patients that come here love us, and we get good reports, we get good scores. And it's like treating your family, because a lot of these people, you grew up with them, you went to school with them, you went to school with their kids, or it's such an integrated group when you're in a small town like this. And so it's about people. And when they're here, we want to make sure that the experience they have is as good as it can be. And sometimes you're here for great things, like having babies, and babies are making people happy. And I always joke, but every time I hear we're having babies, I'm thinking there's another contributor to our Social Security and our Medicare, as we try to get that shored up. But sometimes you're here for things that aren't so good, and sometimes their outcomes are not going to be a good outcome. And people kind of know that going in, and it's kind of palliative things that we do sometimes. But it's about the patient experience, and we've got to be consistent in what we deliver to those patients. And whether you're in food service, preparing their meal, whether you're in housekeeping, cleaning their room, whether you're in nursing at their bedside, or respiratory, or imaging, we all have a part to contribute to make sure that experience is as good as it can be. And that every patient, every time is so important, especially in a community hospital, because you guys, you know that the way that if we can't always do something, then when they get those questionnaires from the government, it says, did they always take care of your pain? Did they always communicate? Did they always discuss this or that? It just takes one time. It takes one time, and they can't say always. And when our volumes are not as big as the big city hospitals, it doesn't take a lot to make to skew that number. When we know that we're doing a great job, but it's got to be every patient, every time, and it's tough, but it's just trying to be consistent. Let's see if I break it. No. All right, and I know I've talked about these before, but I really want everybody to be able to verbalize kind of what we're working on. And I think the biggest thing we're working on that you guys are seeing is the strategic cost reduction. But we're still working. We'll be working on physician recruitment and acquisition. I'll talk about that. The hospitalist team and what's going on there, and then just kind of improve our medical district piece. Greg's going to talk some about what's going on with taxes and things. So we've been doing strategic cost reduction now for about a month and a half, maybe. And we set a goal to reduce operating costs by $1 million. It's really 1.7. The 0.7 was part of what we did with some staffing things. So that's kind of done and behind us. So now we're just focusing on the 1 million. And we've made up 5 teams, and I've used this process in several other hospitals, and it works really well, where you make up teams with department heads. So the first team is a senior team, and then each team has a goal. And the goal is based on how much that particular group of people are responsible for in an operating budget. So we're responsible for about 10.2% of the total hospital's operating budget. So we get 10.2% of $1 million, which is $102,000. This team has about 16% responsibility. So all their budgets added together add up to about 16% of the total budget. And so that's how the goals were set. Who needs to sign in? All right, let's pass this on back. Pass it around. Thank y'all. And so so that's how we set these goals. And it works really well. It's so much better than coming in and saying, look, just everybody cut 2% out of your department. 2%, 2%, 2%, 2%. Everywhere just cut 2%. Because if you're running a really lean show, you may not, 2% for you may be really tough. And if you're running something that's not so lean, well, 2% is easy. You could maybe do 5 or 7, and you could maybe only do 1. And so it's better to get everybody together. And the teams are kind of cross-functional. You'll see a different group there. They're all different areas. They're not the same areas. So we try to blend that because you get a different set of eyes looking at someone's, what they're using, what they're spending their money on. And it kind of says, why do you do that? And do you really need that? And it kind of helps push each other. We try to have tenure, a balance in tenure, where the employees, some have been here for a long time, some have not, so we try to have the tenure of the team to be about the same across the 5 teams that we have. So that's how we put these together. And it's a really good process that I think has worked well. So Team 2 and their goal, and Team 3 and their goal. So they're all pretty close. Team 4 and then Team 5. Am I in your way? Can you see okay?
You're right in the middle.
I'm right in the middle. Is that better?
Mm-hmm.
All right. And so, again, like I said, our goal was $1 million, which is about 5%. Well, the total of the 1.7 was 6.7%. Total post savings to date. So the teams have been working. They've been proposing things. Some of those things they've already implemented. We've already had some savings. Some of the things we are gathering, kind of go through and decide. Some of the things we'll even take to board. And I don't know if we have one of our board members in the back. Pat Check, thank you for coming. I appreciate your commitment to being here. And but so it depends on what it is. But the total savings right now we are at $764,471. So I mean they've been working really hard, which is because everything's kind of based on tens there. It's 76% of our goal. So we are 3/4 of the way there, and we still are working on this until about the first week in September. All right, bless you.
Thank you, sir.
You're welcome. So I think this process is going really well, and it's helping us kind of close that gap and reduce that cost. It's not the be-all, end-all. It's not the final answer. It's part of the solution that we need to do as we try to reduce and improve the operational performance of the hospital. So. All right, the next thing is we're working on acquiring Parkside. We've been working with Dr. McLeod for the last few months, and he is interested in having his clinic become part of a hospital, and we are really interested in him doing that. And so attorneys are kind of finalizing the languages to get it all where it needs to be, and we're hoping, he was in my office this morning, and we're just putting some final touches. We're hoping to sign that stuff today or tomorrow. And that we want to get in there with Wanda and Tammy and do an orientation in the afternoon on the 8th, and then our go live date right now is set for the 11th. It's tentative. I mean, there could be something that pushes it, but that's what we're looking at. And again, what's proposed in is that Dr. McLeod and Summer and Jeff will become employees. Never wants to shut off this morning. That's all right. Happened this morning too. And so, again, we're still working on those things, so they have not signed stuff, so they're not yet employees. So it's, like I said, it's proposed, but we are very, very close. Dr. Denton would be proposed that she would then be contracted. So contracted basically means they don't get benefits. They're just contracted. Versus employed, they're getting benefits. But they're really all kind of still considered employees per se. And then the clinic staff would basically come over as employees as well, kind of like we just did with COVID back in September. So, any questions about that? You know, it's so important to have the primary care doctors really see themselves as a part of the team, which I think is why having them become part of us with an employee model makes that even more tangible with those guys. And I mean, they're the ones that write the order, they're the ones that help make the decisions, they're the ones that can help us control our costs better. They're the ones that can also talk to the specialist about, hey, I want to send you this patient, but I'd really like you to do that patient's diagnostic stuff at Quero Hospital and keep them at Quero if at all possible. And you know, if they're really committed behind that, they can really make those things happen. They are such an important driver for us and for community health care. And so I think that's why these kind of things are so important. The hospitalist program, that's getting ready to take off. And I really want to go through, you know, why are we doing that? And I got to put my glasses on. It's just a little bit too small for me to see from here. It really kind of started because I think before I even came here, one of the physicians had Dr. Garza come and speak to all of them about the hospitalist program, what it means. And at that meeting, I think it was about a 50-50 or 60-40 split in wanting to have a program like that here at the hospital. And so then when I came, I had come from a place where we've been using hospitals, and it was really good for us at the hospital, and it was really good for the providers because they were able to stay in their clinics and be there for their patients and not get pulled over. And so it was kind of a win-win for everybody. So we started going down that path. But, you know, the real drivers for us, it's going to help us with this inpatient observation issues that we have and trying to decide which bucket they go in. And it's really, some of it's dependent, very dependent on how they document. I'm looking at a couple ladies that deal with this stuff every day of their lives, right? And so if we've got someone who, this is all they do, this is what their whole bailiwick is about, they're going to do a really good job understanding how to document better, more thoroughly, because they're going to be committed to having the time to do that. And so I think it'll help us with this inpatient observation piece. Stage 2 meaningful use, that is all about the government, and they have dollars that they want to give us if we meet certain criteria. And it's not like we're getting free money, because we've already spent a bunch of money to get where we're at. So they're basically just giving us some payback on things that we've been doing to get there. But it's really important for down the road that we try to get to that point. And having the hospitalists here where they will have time and be spending their time devoted on documenting in the electronic medical record to make a big difference. Improve our case mix index, that's what CMI is, by documenting the patient's diagnoses and comorbidities more thoroughly. Again, you know, they'll be, I think, better and more fluid with using the electronic medical record. They'll understand the terminology that CMS is looking for, and they'll be putting that in there, and it'll help identify that this patient is really sicker than we have been documenting on, you know, and getting all that stuff in. Because it takes time. And now, you know, our primary care guys, they want to come in, they want to see, they want to get out. All right, and so it's time consuming to do that documentation. So with the hospitals, they'll do that, and our case mix index will increase. And when that happens, our reimbursement for a sicker patient gets better. Decrease our cost of care by following clinical pathways more closely. And I shared that with the doctors and class medical staff. I kind of showed what each of them costs us to manage certain diagnoses, and then the pathway that they help put together, if they follow that pathway, what that cost would be. And that cost is below our reimbursement, is below what we get paid. But their cost to manage is above what we get paid. So we've got to get that down. And the hospitals will help us with that because, again, all they do is acute care work, hospital work. And we think that they'll do a real good job of us managing that better. Opportunity for overnight stays for post-surgical patients. So Dr. Garza in Victoria takes care of a lot of the specialists that come here, their patients at night, and they feel comfortable that we do that. And we're hoping that some of that will translate here as well, so that the patients that normally we don't get to see because they go down there to have it because they have to stay overnight, they'll let them stay overnight here, and that'll help us with getting some more volumes. And then we've added some different things into their contract because we think they'll have some capacity. It'd be great if they got so busy with inpatient care that they didn't have time to do this. That would be fine with me because that means that they're very busy. But doing some things like stress testing. So if there's a patient that we need to get out of here and they need, but a stress test needs to be done before we can discharge them. If we don't have one of the cardiology guys here, which they don't come on Wednesdays, they don't come on Fridays, and they're not here Saturdays and Sundays, hospitals can do it and help us get that person out quicker. They can do some of the pre-surgical H&Ps that sometimes aren't done and it holds up or cancels a surgery. We've talked to them about doing sick call. That's kind of a new thing, but if you're not feeling good, and we have to kind of nuance this, how will this actually roll out? But if we're paying them to be here and they're not as busy as we'd like them to be, then if you're not feeling good, you go see them and say, my throat's hurting, or I got maybe some pink eye, and they can help manage that. Now, they're not there to manage chronic diseases. It's just for the quick stuff, all right? And since we're self-insured, it's just helping us save money. We're paying already, so we'll just do it that way. So the status on the hospital's program is we signed a contract with Dr. Garza, so he's going to be the medical director. He's going to have 2 people working with him. Tentatively, one of those is Dr. Gonzalez, but he's still working with her to get that worked out, so that has not been solidified. And then the other one was supposed to be a mid-level provider. Her name was Desiree. She's been doing this for about 6 years in Victoria, but something happened with her family, and she has to go to San Antonio, so he's kind of behind an 8 ball on that. So he's looking. He's got a backup person that used to work in Victoria. I think that's in Austin that will come and fill in. And so the perfect model when it's all running smooth is there are 3 people rotating 7 days on, and then they're off for 14. So 7 on, off, this one's on, then off, this one's on, and then it repeats. And they're on 12 hours a day, 7 days a week, 8 to 8. Any questions about that? How that works? All right. Recruiting. Been working on recruiting. Started that a few months after I got here. We hired a person to help us with that. His name is Chad Riddell. He's up in Dallas. And he has sent us really the next 3 names. Dr. Penentel, who some of you might have met, he was here a few years ago, and they just back then just couldn't get it worked out, but he really wants to come here. His wife likes it. Him and Dr. McLeod have remained in contact and want to work together. And so he came down, we gave him a really nice visit. His wife loves it here, his kids love it here. But he's got a really nice set deal where he's at. He's been there his whole life, and it's his hometown where he's leaving. And so he's struggling with breaking that. But I think he realizes, and we're definitely getting really close, that for him and his family to come here, because where he lives is very remote. And it's like 3 hours to get to any city of any size from where he lives. And they want to be in a place where they can have a little more access and stuff. And they look at us like the metropolis of Cuero. It's 6,000 people, So I'm cautiously optimistic that we're going to get his things worked out. Dr. Eliciovo, she came and visited us. She was up in Austin, and just wasn't going to work with her with what she was looking to do with her schedule and her life. And then Dr. Niguebo, we talked with him on the phone a couple of times, but he really likes academic, and he was offered some academic type positions, so he went to do that. And then Christy Acosta, I don't know how many of you guys remember Christy, but she was here. Dr. Acosta was here doing a residency piece. And she really liked it here. Her and I visited. And so we're going to keep in touch. She's got a little bit of time still. She finishes up, I think, pretty much like in August, September, but then she's looking to start her OB fellowship, which is another year that she'll do. So that'll start in October, November. She'll have a year at that, and then she'll be able to go somewhere. So near the end of next year, we'll start talking to her about potentially coming here. And if she's really serious, we may start doing something as far as like a stipend to help her kind of get a hook into her, to pull her in and do some fishing. All right? Yes, sir.
I'll try to stand over here. I think I know most everybody here. There's some new faces that I haven't met yet. But as Mr. Gjolberg said, my name is Greg Pritchett. I'm the Chief Financial Officer. In about a month, I will actually have been here 20 years. So probably scary to most of you. But anyway, that's what I'm going to take maybe about 4 or 5 minutes, so it shouldn't be too long. I'm just going to show you where we're at, how we did last month, and at the end give you hopefully some good news that we've had. This is the same format we did last forum, where we're at. One of the main problems on our revenues for the month, the main reason we're up here is with our purchase of the, well, not purchase, the acquisition of the 4 clinics that we took over last July, which is helping us on the revenue side. But on the inpatient side, we had 4 physicians that were all out on vacation, and 3 of those were our biggest emitters and users of the hospital. So that's probably, that's part of why our month was so bad. We'll just get right down to the bottom line. Our expenses for the month were $2.5 million. Last year they were 2.3 at this time. And we've had some bad debt increases. And what that is with Obamacare offering insurance, I've talked to several people that, yes, now they've got insurance, but they've got a $12,000 deductible. So they still got to come up with $12,000 out of their pocket to pay us before the insurance will pay a dime. So they can't pay it, it goes to bad debt. So we're seeing that creep there. Supplemental payments, that's extra money, plus our tax revenues that we get in. But our bottom line for the month, as the manager's meeting, was a negative $565,000. Okay. Last year it was a negative $109. But if we go to year to date and see how we're doing against last year at this time, this is through 9 months of the year, we've got a negative bottom line of right at 168,000. Last year we were right at 500,000 negative, but that's a little misleading. In my numbers, I still show in this number right here, this 1.8 million. At audit time, we get that, as Mr. Gjolberg said, we get some meaningful use money from the government to do the computer systems and everything that they want, everything electronic. I booked or received $1.2 million. They took that out, the auditors did, and put it on our 2012 books because that's what they said, that's what it was for, but that's not showing in here. So basically, if you take another negative 1.2 million and add it to the 1.5, at this time last year, we were actually at a negative $1.7 million loss. So that's a long way from down to 168. So we're over $1 million better than we were last year. Okay. Here's our little gap that we keep talking about. That's the difference between what we make on an adjusted patient revenue day versus an expense per adjusted patient day. It has still kept smaller. In 2013, this gap here was right at $406. So we were spending $406 more per day than we were actually collecting. Right now, this gap is at $372, so it's still dropped by $34. It has widened a little bit since last month because of this loss. Last month we were at 357 days, or dollars, I'm sorry. So we're still lower, we're still on the right path, we just have to continue. Some good news, hopefully. Used to, the government would give us supplemental payments every month. We'd get disproportionate share money and what was called UPL money. Within the last probably 3 years, instead of getting it monthly, they hold it till the end of the year, and we never know how much we're going to get. Okay. Well, I got an email the other day that had some preliminary numbers, and I called the people that put them out, which is THA, our Texas Healthcare Association, and asked them, I said, how good are these numbers? And they said they're preliminary, they could change, but probably if they do, it won't be a lot. What we've got coming in then within probably the end of the year, but it's going to go to our bottom line that you saw. I've got $1.5 million supposed to be coming to us. So that's cash, and that'll help our bottom line. Boom, we're back to making money. So there's some good news. And some other good news is on our tax base, we have the mineral rights, mineral deposits, oil and gas money. Those surplus, those appraisals have gone up. So we're going to leave our tax rate still at the 0.133 or 122. So we're not increasing our tax rate. So if your house and your valuation haven't changed, you won't pay any more tax to us. It'll be the oil and gas people that are going to give us that increase. So the amount of the increase, if we go through and the board, we're going to have some public meetings, and if the board adopts that rate and then there's no rollback, everything goes according to plan, that should put another $472,000 in cash. So, two good numbers, almost $2 million, and that'll all hit this bottom line that we had before. So this negative 1.6, we get to add $2 million to it right off the bat. So there's some good news. So hopefully all that happens. It should. The tax should, unless there's something that goes there. And I was pretty much assured that the other money that the government used to pay us on time, which is now at the end of the year, that should be close to the amounts of money. So there's some good news coming. So it's not all doom and gloom, hopefully, finally. Okay? And I think Ms. Elaine Post is next. I thank you. And like I said, things you're doing are working. That difference going from 1.7 or 1.8 million last year, we're only down to 168,000. That's a big change. That's everybody working.
And I don't want to make it sound with this talking money, because it's more than that. But you got to have that to keep the thing rolling. You understand that? And if we want to buy a new machine or we want to replace an old machine, you can't just break even. You got to have a bottom line that uses to make those capital fixes. Yeah, I worked for Sisters for a long time. And their saying was, no margin, no mission. And that's a group of people that are very, very mission driven. It's about providing quality care to the underserved and underprivileged. And for them to do that, they had to have a margin so that they could have the resources to provide this care to those folks. You know, for us, it's the indigent and the ones that just can't afford to pay. So, you know, it's important, this stuff that Greg's talking about. So I just wanted to
Well, thank you all for coming. We appreciate your time, and we're trying to get you out of here in an hour today. So I only have 2 slides, and both of my slides are good news, so I'm really excited to get to tell you about them. You all know, you've seen the construction down Esplanade about our new wellness center. And it is just moving right along, and we should be open the first week, second week at the latest. We're looking at September 8th at our new facility. You can see there, we have an upstairs walking track, an indoor walking track. Over here is going to be the office to check in, and right in there where you can see that little window is a playroom for kids. It's really going to be an awesome facility, guys. If you haven't joined yet, you should consider joining. Have a racquetball court, the swimming pool, and we're just so excited. Now, in the move, you know, it's going to be a little tricky to move from one facility that's operating 24 hours a day to another one that needs to be operating 24 hours a day. So we're going to experience just a couple of days of closure in there. But I think that, you know, everybody will bear with us, and it will definitely be worth it. So we're really excited. You'll be seeing some move real soon. My next good announcement is we've got changes happening in dietary. We've got breakfast coming. You guys asked for breakfast a couple of quarters ago. Well, you're finally going to get it. Angie got some help in there. And so breakfast is going to start on August the 4th, which I think is this coming Monday. Yeah, so no more McDonald's. You can come here and get your whatever you want, taquitos, all kind of good stuff. We are going to have some changes with our salad bar too. I know we've had some people complain that if you put it in this little container and if you fill it too full, then you get charged an extra amount. You don't have to worry about that anymore. We're going to start weighing your salads, and then that solves the problem. You can pile as much as you want in those containers, and it's not going to be a problem. And it's a very reasonable price. Angie has, we're going to make some signs and put out, but I think Angie sent you all a Meditech email and has told you where you can see what the breakfast menu is going to be. But salad bar now, you can just have all you want in it. I think it's like 23 cents an ounce or something. So a whole pound's only $3.68. So you can eat all you want. We also are going to have sandwiches a little bit more available now. And we are going to have to go up a little bit on our food prices. Not a lot, just a little. We have been charging the same thing, I think $2 for meat for years and years and years. And you all know the price of groceries has gone sky high. So we are going to bump it just, I think, 50 cents and hardly anything on the veggies, I think a dime. So you'll still be able to eat for less than, what, Angie?
I think it's $4.60.
You'll be able to have a meat and two
Sides.
veggies for $4.60.
Add your tax and still less than $5.
Yeah, so it's going to be reasonable, but I hope that you'll just bear with us on that because we do have to make just a little bit of a change. But breakfast is coming, so, that'll kind of make up for the, oh my God, I'm going to have to, have an increase in my lunch. But I think it'll be good. We also are going up on desserts and soup. The soup that we've been starting, we actually lose money every time you guys buy a soup and every time you buy a dessert. So we just are forced to go up a little bit on those things. And like I said, this all happens on Monday. So check your Maddie tag. We'll have the prices posted out there. But I hope you'll enjoy it. And Angie's going to make some different changes to the salad bar too. So add some more goodies in there. And I believe that Judy is next. Thank you very much.
Hello, everyone. I'm Judy Kripala. I know 99% of you, but I'm the Chief Nursing Officer here at the hospital, and I'll just tell you, I've been here 30 plus years. Started really young. I only have one slide, but this slide is very important because there's been some major changes that are going on here. I know we all feel the changes, but I wanted to make sure that you realized what was happening. And one of the changes is to meet meaningful use. And what that means for us is when we meet meaningful use, that's all with the computer, with the physicians documenting, the staff documenting, the patients and families going into the portal, checking things out. That'll mean an additional $600,000 for us, right, Greg? If we meet these guidelines for the government. So what we've done is, number one, is that Melanie Fredericks, our med-surg manager, will be changing full-time to the computer. She'll be changing full-time to information technology and going under Arthur. She will be the nursing informatics and doing all that. The other thing is that J.D. Davis, J.D., he's our respiratory therapist manager. He has stepped down from his position. And Brenda Martin has taken that position. Brenda Martin's been with us for a long time. She will be assuming the role of the manager in respiratory therapy. And JD will then be working 2 days in IT or in the computers and then 2 days with respiratory therapy. So that's going to add more manpower to meet meaningful use that we need to meet. The other thing is I'm not even sure if y'all know where JD's office is. Do y'all know where it is back by EMS around in there? JD and Freddie Solis. Freddie Solis is our EMS manager. They're going to be changing offices. And the reason for that is that will line up all of the IT department together. So then you'll have Melanie and Susie and Arthur, JD, Christine, all of them in a line together. That way they can yell across the hallway and ask what's going on, or have you done this, or whatever. And Freddie's just moving to the other one. So that's the major changes that are taking place there. And that's actually all I have for you. Now, Ms. McMahon.
Thank you. And I know most of y'all too, but for those of you that I don't, my name is Denise McMahon. I'm the Chief Quality Officer, and I've only been here 25 years. So I'm young. First of all, congratulations to each and every one of y'all. The hospital received the Bronze Award at the Texas Medical Foundation for our quality improvement. What they did this time is take into account our readmission rate. They've never done that before, and they looked back 2 years, and our readmission rate at that time was rather high. So we did not get the gold award because of our readmission rate, but we met the gold level for all of our core quality measures. So we're working very hard on our readmission rate, and so this next time we are going to get the gold again. So anyway, we, Mr. Gjolberg, Mr. Wheeler, the board chairman, and myself went to Austin, received the award. It was very nice, and we are in good company. A lot of good hospitals received the award. Out of 333 that participated, only 176 received an award. So we feel very honored. And also, there are some pins up here for the award. If you want one, please feel free to come get one. HCAHPS, how are we doing? And this is a little confusing for people because if you look at our current graphs that are posted in your department, that shows our current HCAHPS scores. And that's from the second quarter of this year. These are what are posted on the CMS Compare website. And so they are about almost a year behind because once they get the data and they aggregate it and they get it out to a website, this is from third quarter of last year. So this won't match up with what you see that is current with us. So they're about, like I said, a year lag. But as far as how we're doing in comparison to citizens and DTAR, responsiveness of staff, we were at 73%, DTAR was at 66, and citizens was at 70. Texas average is 69, and the national average is 67. So we're far exceeding those. So we're doing very well with that. Pain, always well controlled. During this period, we were at 78%. DTAR was at 72, Citizens was at 73. Texas average 72, and national average 71. As you'll see, our current quarter, we went down quite a bit in pain control. And like Mr. Gjolberg was saying, our numbers are very small right now. So out of this past quarter, we only had 35 people complete the survey. And so we had 2 people that didn't score as well on pain control, and it really skews your numbers when you have that low patients. So that's why it's so important, every patient, every time. So we can keep those scores up. Room and bathroom always clean. Our housekeeping department is awesome. Cora was at 82%, DTAR was at 70, Citizens at 76, Texas average is 75, national average 73. That is a very hard score to get good on, and our housekeeping department as well. Cora Home Health on their age caps, their overall care. They were at 92% with the Texas average being 86 and the national average 85. So they're doing well also. And again, patient communication in home health, they were at 92%. Texas average is 86 and national average is 85. So in the years to come, we will start seeing ER HCAPs. That's coming down the pipe. And then we're going to be seeing physician office clinics. They're going to be having some HCAPs too. So everybody's going to be scored. So. That's it for me.
All right. So, what I wanted to do, would you mind flip that light down? Is questions and answers. So, what questions do you guys have? Thank you. Got a question? And I have some questions out of the box that I'll start going through those. But if you guys have questions anywhere, this is a time to ask. We don't bite.
On our billing, I guess this is directed towards Greg. If we have bad debt, are we turning it over to collection?
Oh, yes. Oh, yeah.
We contract
We
with
give 3 billing cycles, which is 3 months. And if you don't come in and make payment arrangements or some kind of contact with us, you go to a collection agency, which then in the end, if you don't start paying them, you will wind up at a credit bureau, which could ruin your credit score or help weaken your credit score.
Yes, ma'am.
So if you're turned over to collection, are you able to come back in to be seen?
Oh, at this point, yes, but we are changing our policy. Laura, she was here earlier, but we're working on it to where what we're looking at structuring it is if you've got a lot of bad debt on our books and if you're coming in for a non-emergent service, either outpatient or elective, we're looking at requiring you to pay 100% of that estimated bill up front, and then sort of suggest you might want to start paying on your old accounts so this won't happen again. But in the past, we weren't allowed to be that aggressive, and we may not be that aggressive this time, but we are in the process of changing our payment policy up front.
Looking at doing that. What do you guys think about that?
Well, I'm on it. Since I've gotten a bill 4 months in a row that was paid in April, I'm not going to credit, am I? No. Okay. I paid my bill in April to the clinic, and I have still got I got a bill last week for the same
It was
bill.
just timing then, so by the
4
time
months I got charged for that.
So
That got paid.
I know that we
So I don't
are.
want to be sent to a collection
No,
agency
no, no.
3 months is our policy.
And if you are sent to collection agency, and we do make mistakes, so if you get a call or a bill, you come talk to the business office, and we'll look it up and say, oh yeah, we can call it back. And then it comes back to us, and the collection agency doesn't have it anymore.
I don't know too many places where you can go and not pay your bill and keep going and going. You know, I know Greg does a great analogy about going to HEB. You walk up to the counter with a grocery cart full of stuff, and say, "Well, you know, I'll just pay you later for this." It's like, oh no, no pay, no get, you know, and food is a vital thing too for people as is healthcare, but, you know, they've got to keep going too, so. Other questions? You guys got some good ones. All right, well, I'll read some of the ones. We won't get through them all, but we'll do the best we can. Let's see. This question was, why is Andy Armando going to all high-level management meetings and acting like he is everyone's boss when he isn't even employed with the hospital? All right, so for those of you that don't know Andy Armando is a nurse anesthetist, right? He works in the OR, and he is contracted through a company called MCare to provide us that service, him and Paul. And Andy has been a part of this hospital for a very long time, right?
10 to 15 years.
Yeah, you know, he lives in the community, his family's in the community, he's vested in being here, and he came to us and said, you know, if you guys would have me, I'd be willing to help you with giving you my thoughts on how the hospital should be done. And he's got great insights, he's got great rapport with a lot of physicians because of his work with them in the OR. And we talked and thought he would be an asset to have part of the senior team, and we don't have to pay him for it because he's already getting paid through MCare, and so he's basically kind of volunteering that time. But he's taken on some good responsibilities for us. He provided us with some really salient thoughts and advice and a perspective that is good. And he's also kind of, with the acquisition of the Parkside Clinic, he has kind of taken that on as the lead on that, which is really helping me and us a lot to get some of those things done. And he really wants to contribute to make sure that this place stays here, you know, for the next 50 years, next 100 years. And so that's the question about Andy. Anybody have any other comments on that one? Okay. Let's see. Why is it that certain people get special treatment due to their wealthy status, last name, well-known to the community, or whatever, are only the wealthy privileged at this hospital now? I'll say a few things. I don't know if the rest will chime in. Everyone should be treated the same at this place. You know. Now, if somebody with some notoriety or a dignitary or whatever comes in, I might go visit them, or I might not go visit everybody because I just don't have time to do that. And that's kind of a respectful thing to do. But we should not be treating anybody any different for any reason. You know, everyone should be treated the same, and it should all be treated with excellent care. And so it doesn't really give us a lot of detail. It's just a question about that.
Every patient, every time, the same.
So. But if you guys are seeing things like this, or you're perceiving this kind of activity, let us know, or let your supervisor know. All right. So
some of that might come from, and I know this is from dietary point of view, or not point of view, but knowing that someone will come in and they'll say, oh, that's such and such mother, or that's such and such this, and that's such and such, you know. Any other patient you don't hear anything about, but if it's a certain person, they're like,
okay,
it's that. So it may not be so much that we do give it, it's just that they are identified out where most patients wouldn't be.
So I mean, you know, and we might identify certain people, and we have to be careful with HIPAA compliance and things of that nature, but if someone who's since, you know, given a lot of money, that's again where I might go up and say hello, and if I haven't met them, introduce myself and tell them we appreciate, A, you choose Craig Community Hospital, B, we thank you for the contributions you've made to us and to our mission here to serve the people of this community. And that's more of just a kind of a nicety, I think. That's probably just being respectful. Let's see, there are many other departments that are not involved in nursing, but contribute just as much in their own way. Those other people are talked down on or treated like they are beneath some of the nurses. Not all, but some. With the majority of the senior leadership team members being RNs, it is pretty obvious to me and many others that these members always take up for the nursing staff. So with that being said, how is it that that is not discrimination against non-nursing staff? So, tough questions, you know. I think when I'm at the meeting with these three, they are nurses, but they represent other departments, housekeeping, food service, EMS. These guys fight for those departments as much as they fight for nursing. They are not saying, I mean, they're not throwing those guys under the bus on behalf of everything. I can assure you of that. It's not happening. And so that is what's happening, and we would not allow that either, you know. And but I will say that if people are acting that way, that's a behavior thing. I get upset when people get mistreated, but if people are mistreating you or your coworkers and being talked down, that's not acceptable at all. I don't care if they're nursing or whoever they are. All right. So you need to talk to your supervisor about that, or come and talk to us about that. That's a behavior problem that needs to be addressed. So any other?
When we're at that table, guys, everybody's important. Everybody's equal because we're in this together. We've got to make this hospital survive. And it can't just be one department. It's all of us together. And that's what we have to know, and y'all have to realize that we're all in this together. And this hospital will survive. We're going to be here for the next 50 years. And we all have to be on board with it. So.
You know, we're doing a lot of tough things. We have to making tough decisions. This cost-cutting stuff is about trying to get things under control, working hard to do things that are going to help us have more volumes. But it's a hard time. It's a hard time for a lot of hospitals in this country. Hospitals that aren't doing well are closing. Greg was telling me that one just closed North Carolina recently. You know, it's a hard time in healthcare across the board. And it's not easy to do some of the things that we have to do, but we have to do what we think is the best thing for us to have a future for the community and for each of us, you know. And so it's not a burning platform, you know, but we have to feel some urgency that we have to do some things to get us kind of back on track a little better. So when will people be told about layoffs again, before or during? And first I'll tell you that there's no plans to do anything else with that. Now, teams are meeting and they may come up with some things, but that's not something that we're doing, not something that we're looking at. All right, and layoffs are a very hard thing, and nobody likes them. And I've been a laid off person. When I came in on Friday, it's like, we're going to have to end your job. And it wasn't anything I was doing, it was just what happened, you know. And go home and tell I wasn't even married yet, I had to tell my wife we were going to get married in 2 weeks. I don't have a job. But it ended up, you know, it worked out. But, you know, to be respectful to people, we don't go out and talk about any of that until we talk to the person first and say, we're very sorry, but this is what has to happen. And it's not a performance thing, it's just an economic or reality thing. And then when that person has had that discussion, then we would go and tell the other people. That's just to be respectful and do it properly. So, let's see. Question, patients complaining about cable TV not working, too much static. And we are agreeing with this one. Not that we disagree. We are working on this one. And in fact, Freddie was telling me, he had a bid some time back about this, and it was a big number, 55 grand, and they tried to come in and rewire the building. But we know we need to work on it, and I think Freddie and Arthur are talking with.
We talked to DirecTV, and they're supposed to be sending somebody over to do an evaluation. So DirecTV. So
we may look at providers and things, but yeah, we just did sign a contract apparently with Time Warner, so we may have to.
We got a cheaper price from one of those bundle deals.
Oh, we did,
and we got some more internet that's coming. So we ought to speed up, not upstairs, but at the computer. Well, it'll be upstairs too, it's all around. But
so quit talking to DirecTV?
Huh?
You want me to quit talking to DirecTV?
No, I still talk to them. Have their thing, because that might give us a lever on these other guys.
Yeah.
Because the contract A is not indefinite either. So.
The patients upstairs are complaining a lot about the quality. And they're just laying there, they have nothing else to do.
I know.
It's very important to them.
It
Same
is.
thing with the internet.
Yeah.
And
that's one of the
that
questions.
it's slow or that it's just not working. But I know I talked to Christina. Last week we had an issue, or it was this week?
This week.
What was it was something kind of simple.
Yeah, just reboot the router. I guess.
Yes, we had to reboot the router.
Apparently going. We had just never talked to her.
Right. So the internet now is not, there's no splash page where you have to log in to the guest network. It's just, you just can log right in. So we took that splash page piece off to make it easier, and we're kind of monitoring that. I mean, our internet pipe is only so big, but I think the way Arthur has it laid out is what we need to run the hospital, that part is carved out and locked down. So they can't pull any more out of that. So their piece of the pipe then is what's remaining for the guest. And but again, they can just log in. If it's not working, then it's got to be something with the router is not working or internet completely is down. So if you have internet at the computer at your desk, but the patient's saying it's not working, it's probably a router issue and needs to be rebooted.
But they got to tell, I don't know if you said you tried to get with Christine in the past or somebody, but you got to let, because I'll call Arthur in the morning when I come in and the internet's real slow or something, and I'll call him and say, Arthur, what's going on? Yeah, there's a problem, we're working on it. So I'll tell him, put an email out. But if it's upstairs on the wireless, I don't use that a lot. So if that's not working, somebody's got to let them know.
Let's see. Will there be anybody to talk to when workers are truly frustrated and need to vent? And not sure exactly. I'm assuming when they're meaning frustrated with things with work, if it's things with family or personal. But if it's work related, well, even if it's anything, hopefully you can go first to your supervisor. If that person is the source of your frustration, then maybe you would want to go to your supervisor, or always go to HR. All right, Tammy and Wanda, go talk to them if you're having some issues, and then they can bring it to us, and we can talk about it. All right, so human resources is exactly what it says. They're a resource for employees. All right. We don't really have an employee assistance program where we have someone that you can go to help you with issues outside of work or issues with finance, stuff like that. But we've been talking about that. We don't really have anything like that. So we do have a volunteer chaplain. So if it's a matter that might need spiritual things or there's some words of wisdom, Mary Ann, thanks for being here, is here, I think, almost every day. So, let's see. How much in-cash reserves, aka money in the bank, does Cuero Hospital have in the bank? And at what percentage rate are we earning on it?
Public hospital, it's not like we're broke, guys. We've, as of the end of June, we still have $17 million in the bank and invested. As far as rates, you all know they're in just are none right now. So our depository is paying us 0.3%. And hey, don't roll your eyes. That's one of the better things going. So we're getting that. And then on my investments, which are government notes, bonds, Fannie Mae's, Freddie Mac's, CDs, I'm getting anywhere from around 0.6 all the way up to 1.5% on those, because I can go out longer on those. My max I'm allowed to invest is 3 years, so that money's there. So all together we have roughly 17 million in the bank. Out of that, about 3 million is set aside and controlled solely by the board, and that's called funded depreciation. So out of that funded depreciation is what a lot of these things you're seeing that we're purchasing, like the clinic, the Omnicell that was just purchased, all that money, because that's what that's designated for. So our balance will be coming down a little bit, but hopefully when the 1.5 million come and then the new tax rate starts coming in, that'll build those funds back up. But that's where we're at. So we're not broke. And then we actually, they call it days of cash on hand. And as of this month, we're at 207. What that means is if we collect no money at all, nobody pays a bill, no insurance money, I mean zero. You collect zero a day at the current rate of expenses that it's costing us to run. We can run 207 days on the cash we have and pay every bill we've been paying. So that's roughly over 6 months. And I think, Mr. Gjolberg, what's your thing on the guy, the finance?
You guys know Dave Ramsey? He talks a lot about having your emergency fund. How long? 3 to 6 months. 3 to 6 weeks. So, and the board, I think, has set a level of 180 days is our goal.
Right.
So, if you take that money and divide it out by 207 days, it costs about $85,000 a day to run the hospital every day. So that's things we buy, salary we pay, electricity, all that kind of stuff. So, and the more we can work to make 85 go down to 84, go down to 83, the better it is for us.
The 7 months we implement the full, hopefully $1 million in savings, boom, that ought to go up. The expense per day should go way down, not way up.
All right, let's see here. One department recently got brand new 55-inch TVs in their patient rooms. How is this possible when we have no money?
That would be me. That would be OB. And they got 3 55 inches and 2 42 inches. Angie's saying yes.
I know, but there shouldn't have been any. Was that
Well,
necessary?
let me finish telling you. OB had 26-inch TVs. Do you know how big that is in that patient room?
It's from here to that door over there, at least.
We're trying to increase our OBs. And that will bring more babies, more ladies, and families into this hospital. Also, we had a physician's request, too, that they needed larger TVs. So our hopes of building OB, that this was one of the things we did for patient satisfaction. There was $100 difference between them.
But the thing is, you're popping out this child. How many women in here sat there and watched their TV while
Well, it's not just about
Why
It's
does
not
schools
just about
do?
the
Because
child.
I work in OB, and a lot of them have their TV on from the time they get there all night long, and even in labor.
Well, aren't
And then
the
the
ads?
spouse.
Hey, whatever their reason, it's their reason. It's the
And we're cost reduction, don't do this. It could have been like, well, could we wait a little bit?
Cost reduction doesn't mean we quit spending money, though. Like we just approved to buy the Omnicell piece.
Yeah, but that's
There's
a
a-
great big.
Yeah. You understand, there's patient safety issues there, there's quality issues, there's a lot of reasons to have that, and there's a return on that investment that it'll end up covering itself in about 2.6 years, and then we end up saving money every
OB
month.
part, I guess, I know, majority is Medicare.
But when the floor got
It's still money, Georgia.
There's obedience.
It's still money.
TV.
And I think maybe if it had been one of those things, I think it's the 55-inch that is the big, oh my God. If it had been, and that's something that I heard, if 32 inches is good enough for upstairs and all their patients who are stuck in the room for 7 days maybe, then why an OB for a patient who's going to be here 2 days only getting 55-inch TVs? And maybe not so much the dollar amount, but I guess the extravagance that it looks like. If this is good enough for these patients, why do we have to do this for this? That's
I
kind of
know,
what you
the
hear.
room is almost double as big.
A 32-inch TV from me to you is about the same size as a 55-inch TV from me to the wall, as far as how big it
But
is.
what I'm saying is, it wouldn't, we all know, when you're talking about people, that's what people are looking at.
Sure.
You know what I'm saying?
We did.
Let's see. Why don't the clinic employees, Bowman, have to pay for office visits? They are hospital employees, but the rest of us have to pay for ours. It is not fair or right. That was a question. And another one here is, if the hospital clinic employees are getting free service at the clinic, why are the hospital employees not? So you saw I talked about like with the hospitalist and trying to do a sick call piece. We think, well, I don't know about this, and if it's really happening, what does this mean? So we have to look at that. So that's one thing, we're looking at
Hang
that.
on, Marilyn, you're there.
It's not free.
It's not free, and I have a bill there, free care,
You get a
And-
discount, but it's not.
just like y'all get a
Like
discount.
we
Yeah.
got. So the question is, where are all the rumors coming
So
from?
maybe
Yeah.
it's just unsubstantiated.
There you go.
But there again, like when I was in the hospital in January, our insurance was not in network. So I'm paying out of network for my doctor to see me in the hospital. So,
Now, you should
no, I didn't.
remember though, we're giving that discount over there, so make sure.
Right, I got the 3% discount, but
then on
still,
top of that, on your self-pay, you get
Yeah.
another 30%.
right.
Okay.
But that's straight from the employee's mouth at Bowman Clinic.
There you
It's
go.
not.
Oh, ma'am, we paid.
All right, let's see. What time are we supposed to be done? 12. Okay, so we're doing, but you said something about being out of here in an hour.
Yeah, we started at 10:45, I thought.
Why are people not able to get along to make the job work?
Personality
And so I think that's a that's a interesting question, and it leads us into talking about something that we've been talking about and want to kind of do a program down the road about kind of personal responsibility, personal accountability, and so it's coming. Who's heard of the book QBQ? Melanie has. It had a big impact on that.
You were the example.
Relatively.
It's QBQ is kind of the question behind the question, and it talks about people that ask questions like, "Why this? Why is this happening to me? Or why is this?" Or it's these why questions, and it should be, you should go behind that. What's the question behind that? Because you have to deal with the circumstance you have to deal with. And so the question should be, what can I do to get along better with my coworkers? Not what can I do? I can't make you do anything. I can provide expectations, behavioral things, and provide boundaries and rules, but we can't make anybody do anything. They have to make a personal decision, to be personally accountable, to behave a certain way. And so this book has been very good as another one of these Dave Ramsey read books, and then Judy read it, and she said, "You got to read this book." And why don't you talk about? You want to mention it, Melanie?
I just mentioned Melanie because I got this book, and actually Todd Gann's the one who gave me this book, and he kept after me, read it, read it, read it. Well, so I ordered it and I read it, and I went, oh my God, the book is life-changing. It's not just about this hospital, but it's about our personal lives. What can I do to make it better? So I was going to give it to my house supers, and Melanie said she would want to read it first. Well, I gave it to her, and Monday morning she comes back and she says, the book was phenomenal. I'm going to be going to IT full time because that's what I can do to meet meaningful use, to help this hospital. It's the best thing I can do right now. And I went, oh my God, you shouldn't have read the book. Because now I'm in charge of Med-Surg, so God bless y'all. But it's about what I can do. You got to get in your heart, guys. You got to think, what can I do? Because it's real easy to say, it's their fault, they did it, he's doing it. But what can I do to make it better? So we want to circulate some of those books. It's not just about the hospital, it's about your personal life too. And it's a grand book, guys. It's a real easy read. It takes about an hour and a half.
Yeah.
It's phenomenal.
So it's like, you instead of asking why questions, you put in there what or how, and then there's an I, and there's some action. How can I? What can I? Or how should I? Or whatever it is. It's like that. But it's like I said at the beginning. Healthcare today is not healthcare 10 years ago, 20 years ago. It's challenging, and we've had to make some hard decisions. And I was sharing. If you guys ever heard or read Good to Great with Jim Collins, and he talks about Kimberly Clark as an organization, and they had a leader there who was really good. His name was Darwin Smith, and he developed cancer in his arm, and he had to get an amputation, and he learned that in order to save himself, he had to have his arm cut off, and he had to do some things for that company. He had to basically, they were a paper company, but he sold the mills to salvage that company because they were just losing money hand over fist on their mills. And they diversified. And Kimberly Clark is a very successful company today because of that tough decision he had to make back then. And he kind of paralleled it, like I had to have my arm cut off to save my life. I had to cut off the paper mills from a company. That's what we did most of their existence. And we've had to do some things. But again, it's not that we're a burning platform by any means. But we need to get things in line. We got to get prepared for the future that's going to keep coming at us. Don't know what's going to happen in November, but it's very volatile and unstable, and so we need to be as prepared as we can and as nimble as we can. And it's what can I do? What can you guys do? You have to kind of look at it that way. Sometimes we're stuck in our box. We talk about thinking outside the box. Sometimes we just can't. This is all we got in our box. This is what we got to work with. So how can we make the best of it? What can I do to make the best of the situation with what I have to work with? So it's tough, but it's good. It's not, it's a great place to be. This is a great place to work. You guys are great people. I've enjoyed my 9 months here, and I love it here. And you know, it's just harder, a little bit harder. So, you guys have other questions?
I have one comment that I've heard several times. When we have patients that expire, and if there's a better solution, but they put them in the body bag and they trace them straight down the hallway, past our atrium.
Yeah.
People are picking up biohazard out the back dock area and they're loading them in a car. It just seems really I don't know, almost disrespectful, like we're throwing out the trash or something. If there was just some more respectful way that we can have that happen. Yeah. I mean, we just traipse them down the middle of the hallway, and like I said, just out on the back dock where we take our trash out.
Yeah. You know, we don't really,
disrespectful.
the hospital's not designed with what we would call an on-stage area and an off-stage, or like a back of house, where we can segregate that kind of thing. You know, I don't know. Definitely should come down the back elevator by the OR.
If we could just kind of, maybe someplace quicker to go out of the
It's just a
hospital.
matter of educating the funeral homes as to where they can.
Have them go in and go out the ER door.
Out of town.
Yeah, but I don't know about the ER either. I mean,
Oh, yeah.
I'm an ER patient walking in and they're bringing a body. Whoa, is this, you know, I don't know if they get back into one of the ambulance bays. I don't know if that would work. We don't want to tie those up. I mean, the loading dock is the loading dock, but
Well, I was trying to think of a way to keep it as quiet and not visible. And
That's
then
why
it passes by all of you.
It is the most
visible. We don't see them go on the door.
Either way you go, but I've heard that comment so many times, and then like you'll get, oh, you know, when they see the kids, when they see them go by you.
there is a device that I've heard used in hospitals where the patient goes under and it looks just like an empty gurney. But they're,
Throwing used to have something a little bit better. It's
And
like
so
this
you-
blue drape over it, and they were
Right.
kind of
And they still
underneath.
use it.
But now, some of them just come up and they're just in a body bag.
That's what.
That's what they move them in now.
so maybe there's a way that we can make that a little more visually not so,
government
whoa.
restriction on their part.
What, Becky?
It's probably another government restriction on their part, because I know in a disaster, they have to put a body bag. You cannot just drape them in a sheet. And normally, they were just slid over, put a sheet wrapped around them, with their hospital gown, sheet wrapped, and then the blue tarp went over it. And they can't do that anymore.
Maybe they could put that blue tarp over the body bag, maybe.
And using the back elevator and away from patients, they're really less seen that way than any other way getting out of this
Oh,
hospital.
well, definitely the back elevator.
Yeah.
We don't really have a
We
place
don't,
that's not
yeah.
visible, but.
Thinking like a serving car like sometimes you see on the movies. No, it's got the top, it's still square, and the sheet drapes, but you don't know what's in there, is what I'm saying. They can still put them in a body bag,
Because-
but it's
Stay
draped.
away from ER, because
Yeah, you
just
don't-
seeing the hearse.
Yeah, I think we still need to stick with the dock,
Yeah.
you know. What else? All right, y'all. Thanks for coming. Tell your friends they need to come. We got 2 left, all right? And I feel like I'm on the cruise ship. I got invited on a cruise last week with my mother-in-law, and I went, and they're like, the second show tonight is at 10 o'clock. Tell your friends to come. Tell your friends to come to the show. Yeah, there are some more questions. We couldn't get them all. We will write them up with answers, and we'll put them as we did last time. So,
If anybody wants a pen?
sign in if you didn't sign in. If you didn't sign the attendance, then you'll be made to watch the video.